unless Franco or Bill has had the time to learn a few words in Greek, so he could deliver the talk in Greek, but alternatively, we can continue in English. We are waiting for Andre Keren. I hope he's not lost in Thessaloniki down in the metro. We can nevertheless start with my co-chair, Professor Skoularigkis from Larissa, and myself, and Professor Andrew Keren from Saba from Israel. And Franco. Hello, Franco. Nice to see you again. You haven't moved a bit. Did you get up at all during the afternoon, or you've been sitting? You have exactly the same position as you were about 5 hours ago. It's impressive.
Well, this is my position. This is my position.
You know, move your chair
in front of the computer. So
just change a little bit. Okay. All right. So Franco will, Professor Cecchi will talk about cardiomyopathies and update in gene therapy. Franco.
Okay. So, well, thank again to Yorgos and you, Petros, and your colleague. And I believe that, you know, we're now facing a new phase. I remember that talking about mavacamten, that in 2015, I happened to be in the United States, and I was shown, they showed me this new compound that was going to be, you know, very promising. And 10 years later, well, actually, that's what we have. And I believe that possibly this might happen with gene therapy. So, well, actually, I mean, talking about gene therapy, I believe that there is really a wide range of gene therapies approved, patient-treated, and, you know, with a long follow-up for several diseases using adeno-associated virus, so-called AAV, and which is considered now the best vector that could be used for delivering a portion of a gene into some tissues. And concerning cardiomyopathies, we all know that, you know, there are a lot of genes that are responsible, have been considered responsible for cardiomyopathies. So we know a little bit better how to diagnose them, how to deal with them with drug therapy, sometimes with invasive therapy. But above all, you know, we have, you know, we're not really well aware of what could be gene therapy in this kind of diseases. And actually, we all know, for instance, for hypertrophic cardiomyopathy, that there are some genes that might be considered for gene therapy, not only on the sarcomere side, but also on the other side of genetic causes of non-sarcomeric genetic causes. So gene therapy actually is an emerging technique for treating these monogenic disorders. And there are two ways that can be used: introduction of new genes or modification of existing genes or their regulatory portion. So in case, for instance, of genes that cause a loss of function, okay, then you have either the absence of protein or the production of a truncated or anyway unfunctional protein. So the way that, you know, you can deliver a portion of the gene which is defective into the, for instance, cardiomyocyte, which then will produce the correct protein and increase the load of corrected protein functionally working. The other way, instead, when there is a gain of function mutation, then you can produce a protein with increased or different activity, and then you have to cut out the portion of the gene that is working and making the problem, or you can actually then directly correct the gene portion of that is causing the problem. Now, experimental work has been really done a lot in the last 10 years. And you see, basically what you have to start with is the preclinical studies on mouse models. So you need to find a tissue-specific promoter. What does it mean? It means that you need to find a promoter that delivers the virus vector and including the portion of the gene into the tissue that you are targeting, which in this case is cardiomyocytes. Then you have to put the gene product that you want to correct into the AAV, which is the capsid of the virus that then contains actually the correct gene. And then you have to start doing studies in this case to see whether this works. And this is, for instance, the experimental work that has been done with MYBPC3 in mice. And you can see that if in mice that have been treated with the viral vector and with the new gene, corrected gene, then you have really the myocardial mass goes down. And actually, if you see here, the ejection fraction increases in this mice model. And then you see that the survival actually is good in comparison with the wild type model. So this is the basic preclinical type. Then you can plan, the clinical, and you have to consider, however, what kind of disease is, how you have to evaluate, by imaging or by biomarkers, and then by the functional class. Of course, you have to evaluate if there are neutralizing antibodies, which, of course, might block the effect of the new viral therapy. And then you have to start with low dose and then go on with higher doses to understand where this is effective and functional. Of course, at this point, you may have some immune response, so you have probably to use some drugs to block or at least to lower the immune response. And then you have to assess the outcome. So this is basically the process, the workout process that can be done, if you want to do an experimental gene therapy. And actually, this slide, I already showed it last year. In 2023, these were, the trials that were going on. Most of them in phase 1. Okay. In several different genetic diseases, TTR amyloidosis, which you heard right short time ago, Pompe, then Duchenne muscular dystrophy, Friedreich ataxia, Fabry disease, Danon disease. And this is an updated list, updated list just published by the French colleagues, including arrhythmogenic cardiomyopathy, which is now really in this moment, it has several trials going on. And look, for instance, just a very recent paper published in New England just a few weeks ago about LAMP2 and the phase 1 study results, which were rather good. However, there are a lot of papers also coming out about the possible complication and problems like liver injury or, for instance, vector-related myocarditis, just recently published by the group of Adler, including our colleague Alessia Giraud, works in Florence, and he's been working for 6 months in La Jolla in California. Now, what happens for hypertrophic cardiomyopathy, which is the method, which is something which are interested very much in? It's the most common cardiomyopathy. So here what you have a loss of function with the insufficiency of MYBPC protein, about on the average 60–70% of normal, and which is responsible of the symptoms and of course of the disease progression. Because this protein is necessary for normal structure and sarcometic function. It modulates contractility and relaxation. And this is what happens, in animals, when you have a loss of function variance. You see that you have disarray, and you have then, of course, disease progression, hypertrophy, fibrosis, and so on. And if you inject in these mice the viral vector, including the corrected gene, then you have a restoration of the muscle, the histology. Basically, this is also the process. I mean, the mechanism of action. You have the viral DNA removed from the capsid. So you have the capsid, you insert the new gene, the new portion of the gene, which you want to administer. Then you do an infusion, and the infusion through the promoter goes directly to the cardiomyocyte. It enters the cell and it enters the nucleus. And then, it can produce through the ribosome and RNA, of course, the corrected protein. What happens at this point is that, the transgene, the new gene, including the corrected one, forms what we call an episomal DNA. However, this transgene does not integrate into the host genome, but it encodes the correct cardiac myosin binding protein C, okay? And the expression of the gene is durable because, of course, we are dealing with non-dividing cardiomyocytes. So in October 2023, so about 1 year ago, Tenaya started the so-called TN 2001 BP MYBPC3 trial, okay? They enrolled a few patients, adult patients between 18 and 65 years. They needed to have a truncating MYBPC3 variant, non-obstructive HCM. They needed to have an ICD, symptomatic, proBNP at least 300, ejection fraction greater than 50%, normal hepatic function, and they had not to have antibodies neutralizing AAV9. Now, the patient have been treated and everything was okay, no complication. So then they start the phase 1b/2 clinical study, which is called MyPeak-1, okay? So this is the second cohort. They increase the age up to 75 years. However, you do not need any more to have an ICD, and the antibodies can be less than 1 out of 20. And in this case, what happens is that this was the dosage, the viral dosage that was inserted, and which is doubled at this point, as you can see. And then we shall see the results before really having being free of complications and saying that the trial can go on. Because in the gene therapy, of course, there are several challenges. One is the gene delivery. I mean, because gene delivery, of course, must enter the target cells, of course, and then it must express really the correct protein. The immune response is, of course, of major importance because these neutralizing antibodies may increase the risk of immune response or impact the efficacy of the therapy. And then the other issue is the durability of the gene therapy, because we don't know. I mean, in cardiomyocyte, how it will work. We know it for hemophilia. We know it for these other diseases like spinal muscular atrophy and X-linked myotubular myopathy. Moreover, I mean, more and more reports are published about the so-called adeno-associated viral vector toxicity, including the neurologic site, hematologic site, above all thrombotic microangiopathy, which is very important, myositis, and above all myocarditis, which I mentioned before too. Also ocular, and above all hepatic liver toxicity. So we have some issues that must be resolved. So in conclusion, I think that the gene therapy clinical trials for cardiomyopathies are ongoing with early promising results. However, adverse events such as hepatotoxicity, viral myocarditis, and acquired hemolytic uremic syndrome have been reported. Cardiospecific low immunogenic vectors and adequate immunosuppressive regimen are unmet needs, but ongoing trials and different type of treatment have been tried so far and are trying to overcome this problem. And the other big problem is the small sample size, the necessity of surrogate endpoints, and the lack of a control arm make, of course, these trials more and more challenging. However, in conclusion, gene therapy is a dream that might become real in the next future. Thank you very much.
Very nice, but early days still talk, and well, we will monitoring year on year to see some early results. Do we know anything about the cost?
Yeah, that's a big issue, of course, an enormous issue at the moment. It has been criticized. There was a paper editorial in the New England about 4 months ago claiming that this might be a dream for a few people in rare diseases. But what about when you're dealing with diseases that are not rare? How can we afford that? However, I mean, as long as there are investment, I believe that we have to try to understand, because this will teach us better, how to deal not only with gene therapy, but also to deal, with molecular aspects and immune responses. This morning, we've been talking a lot about myocarditis, whether it was myocardial injury or real myocarditis, and I believe that we shall learn anyway from this kind of experiments.
Okay, Andre.
Thank you also, Franco. It was a great pleasure seeing you and hearing you. And it's a great pleasure for me now to introduce Professor Bill McKenna, who is going to clarify for us the aspects of